Assalamu alaikum and good morning. This is the whole long day for physiology, you know that. Okay, we have got 2 lectures and we have to finish. Both topics are very important. One by one, inshallah, we'll take. First, the pulmonary circulation and ventilation perfusion. Then we'll come to second topic. We'll have a break in between so that you refresh yourself, and then we'll load the second topic. Shabab, in respiration so far, we have covered the journey up to the transport of gases to the tissue level. Okay, we started early with how things happen in ventilation. How did exchange occur in the lungs, and then how are the gases transported in the blood, and how these are delivered to the tissues or received from the tissues. Okay, having covered all these things, we are going back to a very important concept which we will understand better now, because now we have some foundation, a background we have already developed. You are familiar with the terms also, and now we'll apply these things. The topic says it's pulmonary circulation and ventilation perfusion ratio. Okay, there are 2 parts of this topic. One part is known as pulmonary circulation and other part is ventilation perfusion ratio. Pulmonary circulation, probably you do not require a very detailed discussion on this one, because it is a part of the cardiovascular system also, the CVS. And in CVS, you have covered the, I think, general aspects of circulation. Maybe not this pulmonary circulation, but we'll talk about this as it comes down. The second part is ventilation perfusion ratio. Again, this is a 2-term topic. One part is ventilation, other part is perfusion, and then you are linking them. You are developing a relationship between ventilation and perfusion. Why are we doing that? Let's see. What do you know about pulmonary circulation, first of all? Do you have any idea about pulmonary circulation?
From the lung, develop to the heart, then develop to ventilation.
Okay, the functional aspect is that it takes the oxygen or loads the oxygen from lungs and then delivers it to the heart. Which side of heart, left or right? Left. Definitely left side of the heart. Okay, and if you compare the other aspect, it is also taking the blood, the depleted blood, to the lungs for the oxygenation. This is all we know about. But if you are comparing this pulmonary circulation with the systemic circulation, what points come in your mind? This is an interesting question. You are comparing your systemic circulation, the main circulation supplying elsewhere, every other part of the body, and you are comparing it with pulmonary circulation. So what differences are there in your mind?
Blood coming out of the heart in the pulmonary circulation is deoxygenated, and the one coming to the systemic circulation is oxygenated.
Okay, this is point, again we are just consolidating that point which we discussed. Anything else we can add? Pressures. Okay, I heard the word pressure. Abdullah, you are saying that? Who's saying that? Okay, Salman is saying that. Yeah.
Pulmonary circulation needs less pressure than systemic circulation.
Okay, so the pressure differences. Okay, which system generates higher pressure? You know that. That is the demand of the systemic circulation, because you need to supply wide areas of the body and you need to have a very high power in that system. Low power, low flow. High power, high flow. Okay. So systemic circulation is a big area to cover all the parts of the body. Definitely your qalb and your system has to generate a very good force so that you can move the blood to distant areas of the body. Okay, Good point taken. What else? Type? Time. Time in the sense, yani, you're saying that the time for... It's a short circuit or a small circuit because qalb and lungs are mawjood together. So it's not really a big deal, okay? It's circulating between two areas and the distance is not much, as you can see, isn't it? And for the systemic circulation, well, you have to reach extremities, yani, the farthest areas of the body which are away. Yeah. So if you're thinking anatomically about the tool of the system, so definitely the tool is different, isn't it? Yeah. Okay. Yeah. Volume given at any time. If you stop the heart and now you want to measure the volume mawjood in your pulmonary circulation and mawjood in your systemic, which system will contain more volume? Definitely. Okay. Major part of your volume is at any given time present in your systemic circulation. Okay. The content or the volume also. Okay. All right. Okay, now let's talk about the structural difference. Any structural difference also between the vessels of the two systems? Structurally, you are comparing arteries with arteries, veins with veins, capillaries with capillaries. This is what you will do. Okay. So what is your idea? Pulmonary system. Permeability. You're saying permeability is what? More, less, same? Well, the factor of permeability, I will say that pulmonary capillaries are more or less permeable like the systemic capillaries. Okay, it's not a big deal really, but systemic capillaries, because they belong to different parts of the body, okay, legs, skin, muscles, bones, other tissues, capillaries are mawjood in every area. So they differ in their permeability slightly. In the liver, in other areas, it's different. So you can have a little low permeability to a very high permeability in different parts of systemic circulation. But in pulmonary circulation, there is a moderately functional permeability, which is okay, right? I'm talking about the structure. Okay, so what do you think about the build of the pulmonary system and the systemic vascular system? Which one will have stronger vessels? Definitely, the systemic vessels have to hold more blood and generate high pressure. So the build, the muscular walls or the elasticity and all those components definitely will be more in the systemic. Okay, now you are comparing the pressures and you say it's the low pressure area, yani pulmonary system, and it's the high pressure area, that is the systemic circulation. Okay, well, especially the capillary pressure is quite different. The capillary pressure in pulmonary circulation is very little. You require a little pressure because you don't want large amount of fluid to go into the lungs. There is a risk, there is khatar. If it goes out of the capillaries and if it doesn't come back, and if there is some problem with lymphatics also, what will happen in the lungs? Edema will develop. Okay, so lungs have to be kept dry all the time. So exchange is going on, but the pressure systems are low. The capillary pressure is taqriban 7, average pressure in 7. Okay, average pressure in your systemic capillaries is 17, taqriban 17, 18 is the pressure. So there is a big difference really. Okay, that area does not require high pressure, the job is done. The main job is to take the oxygen as much as possible and to take it to the systemic circulation. In this regard, you will see the other pressures also, which will come in the diagram. So pulmonary system has differences from the systemic circulation, right? We all agree. Some structural, some functional. Yes, the differences are there. Okay? All right, Shabab. Here we'll talk about ventilation perfusion ratio, its physiological and clinical significance, and we'll see some interesting facts about what changes are there in different parts of the lungs. Lungs are lungs. The upper part, the middle part, or the lower part, the apex or the base of the lung, the medial surface or the lateral surface of the lung, okay? The posterior surface or the anterior surface of the lung. Well, lung has similar structure, but functionally, when you study physiology, you will see that even in a normal lung, it is extending from this part, isn't it? Here, apex, coming down to here. So the lung shows some very interesting changes in different situations, in the different positions that we have. Right now I am standing in front of you. Right now you are sitting in front of me. Okay? Your position is a little different from my position, isn't it? The body position. Okay? Even though both of us are in this posture, but I am erect, exactly standing. You are leaning and you may be sitting a little back, okay, or you are sitting on one side, okay, or you are leaning forward like this, different positions. If you lie down at your back, okay, you are reclining or going back, your position of the body changes. If you are taking a lateral position or turning yourself on one side as you are sleeping or lying down, your position changes. One lung will come above, the other lung will go down, right? Isn't it? When you turn like this lung will come up now and the other lung will go down. So it means the relative positions are changing, isn't it? As we are thinking about the lungs. And lungs are the body structures, they are affected by the body positions. And we will see how position affects the lungs, what happens to the function of the lungs when the positions are changed. Okay? And that will affect your ventilation and perfusion. We are linking our lungs with the ventilation, you know the meaning of ventilation, to the perfusion. I want to know the meaning of perfusion. Can you tell me? Perfusion. When I say the word perfusion, what do I mean by that?
Passing the blood from the heart to the lung.
Okay. He's saying you are flowing the blood from one area to other area, okay, or blood flow. So in simple words, can I say perfusion is the blood flow in any area? Yes. So it's blood flow. Change the word. Make it easy. Perfusion is a good word, but a difficult word. If you want to make it easy word, you'll say, khalas, blood flow. Okay, it's the blood flow which is going. If I say alveolar perfusion, it means what do I want to say? Alveolar blood flow. If I say pulmonary perfusion, generally, I'll say, if I say bronchial perfusion, khususan, I'm talking about the bronchial blood flow, isn't it? So it's the blood flow basically. Now you have to see, when ventilation is going on like this, up and down, inspiration, expiration like this, the blood is flowing from the lungs, from the right heart to the left heart, from the right heart to the left heart, and it's passing through the pulmonary circulation. Do you agree? Okay? Well, we will study this very interesting relationship. At some areas it becomes very complicated and twisted, and you have to understand very carefully what is happening really, okay? How we are explaining things. Be careful. It's not an easy topic. You have to take care of it. It is one of the very conceptual areas that you need to understand properly. Thinking, okay? Apply your thinking. It's not just reading and memorizing. Please. That's your beginning slide, but right now we are not talking about any details. We are just talking about the airflow. Airflow, you know that the flow of the air which is passing through your pipelines, your respiratory system, from your nose to your alveoli, and from the alveoli back to your nose. And inspiration, expiration. Do we have airflow during these processes? Yes. Okay. This airflow is affected by different factors. As you go from one big area to smaller areas, and from those areas to further smaller areas, as in the circulation, the blood is flowing. In the respiration, air is flowing. Okay? So here we'll use the term airflow. This airflow will be affected by the size of the airways. If the airways become smaller in size, the airflow will change. If they become bigger in size, bronchodilation, the airflow will change. If there is some obstruction in the passages, it will be a change, isn't it? So some factors like hormonal factors and the nervous factors are changing the airflow. Okay? If I say nervous factors which are changing the airflow, sympathetic and parasympathetic, you will not talk about the somatic supply or the somatic nerves. You will talk about the autonomic nervous system, bronchodilation and bronchoconstriction. Where will you couple bronchodilation with which system? Okay, and bronchoconstriction? So the resistance or the passage, problem to the passage of the air will change with parasympathetic and sympathetic, as you know. In parasympathetic, Zahma will increase or decrease? What do you think? It should increase. Your system is becoming smaller, isn't it? And when you are having bronchodilation with sympathetic system, what will happen to your airflow resistance? Size of the airways increase generally, and airflow resistance becomes decreased, and there is a better ventilation. So with sympathetic, the ventilation improves, and with parasympathetic, it slightly decreases. There is a tawazun between parasympathetic and sympathetic all the time. Okay, but when we are doing one special act, then we may have this tawazun shifted towards one side. When we are having exercise, where will this tawazun go? When we are sleeping, and in makhsus part, it will go more towards, isn't it? So different factors are changing this equilibrium. All right? Okay. Fortunately, we have some idea about alveolar ventilation because we already discussed that. So we'll pass quickly from this area. Remember, Shabab, I gave you the difference between pulmonary circulation, pulmonary ventilation and alveolar ventilation. We try to differentiate what is the meaning of a bigger picture, yani pulmonary ventilation, and what is the meaning of a special picture which is known as the alveolar ventilation, right? We talked about Jadid and Qadim air. Remember, if you are only talking about the new air which is going into the alveoli, then you are talking about alveolar. But if you are talking generally about all the air which is going into alveoli in 1 minute, Qadim and Jadid both, then you will call pulmonary. We are putting pulmonary ventilation aside. We are talking about the alveolar ventilation now. Okay, the new air concept we'll apply here. Okay, because this alveolar ventilation we are taking in account, and we are matching it with the blood flow which is going in the lungs. Okay, if you remember, it's 350 ml mawjood in one breath that we take. Okay, and then if you multiply it by 12, for example, you will have taqriban 4.2 liters or so. Okay, that is your total alveolar ventilation per minute. Per minute, please. Okay, per breath, in wahid breath it's 350. In wahid minute it becomes 4.2 liters. Everybody agrees, please? Okay, great. That is your animation which is showing you how alveoli are changing their size during inspiration and expiration. We know that, this concept. Okay, they have to become bigger because these are the elastic structures. When the air is moving in, the volume of the alveolus is changing, and then it comes back to its normal position. Okay, this volume may become very big during forceful inspiration and become slightly big during normal quiet breathing, isn't it? Depending upon the requirement, actually, what we are doing. Okay, now look at that one. What is this picture showing? Okay, what is this picture showing? Just try to catch this picture. You know what is happening. One is alveolus is there, and the air passage is also shown. Okay, the air passage which is leading. Now I just want to get an idea from this picture. How do I get this idea? Yeah.
Old air.
Okay, where is the old air, my dear?
Coming out. The
Okay.
airway.
Uh-huh.
If you need new air,
Okay.
push it Okay.
All right. If you see, well, this moving portion, this up and down moving portion, what is it showing? Is it showing any specific structure, or is it showing you any movement? Movement of what? Air. Khalas. So it is air, first of all. If it is air, what do you see in that moving structure? Okay, how many parts are there of that moving structure? Three parts. Well, out of that, what change is happening as it is moving down, and what colors are there? Okay. So what do you mean by the green color here? Okay. All right. Okay. All right. Okay. Well, this is showing you the column of inspired air, the air which is coming from outside. Inspired air is coming. Out of the total inspired air, now how many divisions are موجود there? 3. How many divisions are moving inside your alveoli? It's how many are moving inside the alveoli, going into the alveoli? 2/3. Yani, if you are saying 2/3 of the air which is coming inside, okay, if it is the jadid air, how much of the jadid air is moving inside the alveoli? 2/3. And how much of the jadid air is staying in the passages? We did that before also. Do you remember that? The same diagram is showing you. Okay, so 2/3 of air is going inside, okay, jadid air, and 1/3 is staying in your passages. Okay, so that is depicting the alveolar ventilation. All right. Okay, now you are coming to a very interesting discussion, very interesting part here. You see this diagram, and you see that the inside structure is the lung, okay, which is covered by the visceral pleura, and the outside structure is the parietal pleura, and in between the two structures some values are maktoob. So what is there first of all between the two layers of the pleura? The pressure. So we are talking about looking at the values of the pressure. Now look at the lungs, observe the diagram, and tell me what is happening to these values. This is the lung in this position as I am standing, or as you are sitting in this position, okay, lungs. Now what change do you observe in the pressure? Okay, you are picking two things from the diagram. First of all, what change do you see in the values of the pressure? The pressure is decreasing or increasing? Decreasing. Okay, as you are going from above to down, is it decreasing? Give me one answer. I am simply asking, the pressure is increasing or decreasing as you are going from? Increasing? Everybody knows, okay, because the minus pressure, it's -6, then -3 mumkin, and -1, you are actually increasing the pressure, isn't it? Everybody gets it? Now look at the other side of the diagram. Someone was saying from this side, what change do you see? Size of the alveolus. Do you see that? Where do you have the bigger alveoli موجود? Okay, all right. And where do you have the smaller alveoli? First of all, okay, yeah. So you are linking the size of the alveolus with the pressure. So if the pressure above in the upper parts of the lungs is more negative in a normal person, naturally, all of us normally, okay, pressure is not same throughout the, okay, the average pressure we take -5, -7.5, khalas, average of all areas. But if you consider part by part, this part, and this part, okay, where do you have the highest pressure or the most negative pressure? Most negative pressure? Upper part, okay. Where do you have the highest pressure or less negative pressure? Lower part, okay. Now look at the effect of this pressure on the alveolar size also. If your pressure is more negative above, you have the lowest pressure in the upper part, then what is the effect of that pressure coming on the size of the alveolus? It is pulling or distending. So normally if I consider which parts of my lungs will have relatively bigger alveoli at any given time, upper part. Okay, which parts will have relatively smallest alveoli? The lowest part. Okay, did you get that? Okay, so alveoli are not equal in size because your pressures are different, and that pressures are controlling your size of the alveoli. Okay, so the size of the alveoli are mukhtalif, a little different in different parts. Okay, did you get this idea? Now why is the pressure more in the lower part and why is the pressure less in the upper part? Yes, dear.
Because it's more farther than the sphere.
From the
Sphere.
any other reason? Okay. Gravity is in fact, gravity is a special force which is acting on the solid structures which have any solid structure of the body. Okay. Gravity is affecting your blood flow also. Do you remember that? Okay. Your blood flow in your lower part and your blood pressure in your lower part is affected by the gravity as compared to the upper part. Likewise in your lungs also, the lungs are affected by the gravity because lungs are solid structure. They contain airways, they contain blood vessels, they contain blood, lymphatics, nerves and so many elastic tissue. Yani, they are affected by the gravity. Any structure which is affected by the gravity, it will have a changes in the pressure system. The pressures are higher in the lower part of that system and pressures are lesser in the upper parts of that system. As you go down, your lungs are becoming more solid and solid. Okay, and the solid areas, now you have parietal pleura and the visceral pleura. In the lower part, you have more solid lungs, more blood is mojood in the lungs, weight of the lungs become more in the lower part. So what will happen to the pleural pressure? What will be the effect of parietal pleura on the visceral pleura or the visceral on the parietal? What will you say? They are doing like this. Okay, they are not pulling it themselves away because of the pressure of the surrounding areas. So as you are going down in the lungs, you will see your pleural pressure is changing. Okay, and because of the wazan of the lungs, because of the viscosity of the lungs, your pleural pressure is becoming less negative or higher. Are you agreeing with this fact? Okay, khalas. And this is of course changing your alveolar size in different areas also. Okay, let's see if we are right or wrong. Gravity is the factor, okay, which affects the pressure, and the pressure affects the volume of the alveolus. Okay, so ventilation pattern, let's see. VA is your alveolar ventilation. Okay, so which zone of the lung, lower zone or the upper zone, I am talking about the zones of the lungs, will have a larger volume of the alveoli at any given time? Upper part. Okay, and alveoli are slightly smaller in the, as you have seen, that lower part. Now very interesting part of the story. Okay, be careful now because now the concepts are beginning. You have an alveolus, it's an elastic ball, isn't it, in which you can fill the air and you can empty it. You can fill it, you can empty it, isn't it? There is one alveolus, the two alveoli are equal naturally, okay, but one alveolus is mojood in the upper part of the lung and other is mojood in the lower part of the lung. Okay, the lower alveolus is slightly smaller, and as compared to that, upper alveolus is slightly bigger in size, larger in size. Okay, now if the ventilation is coming in this alveolus and the ventilation is coming in this alveolus, equal ventilation is coming in both these alveoli, which one will be stretched more? Which one? Lower one, because it is smaller in size, it has more chance of becoming bigger, isn't it? Alright, so which one can accommodate more air at any given time? The lower one. Are you getting it? So if I say the compliance of the two alveoli, okay, the upper alveoli and the lower alveoli, compliance means stretchability or expansibility. So which alveoli are more compliant, lower or the upper? Right? Lower have more chance, they have more room. If you keep on filling the air, they will become like this. Okay, upper is already this much big, If you fill the air, it will become this much big and it will not become any more. Okay? So more chance of compliance is موجود in the, do you agree with that? Great. Okay. So if the ventilation is coming equally in all the areas of the lungs and air is getting distributed, which alveoli are filled more and they will receive more air? The lower one will have more. So if you are comparing the ventilation of the upper part and ventilation of the lower part, which one will you say, wow, the lower or the upper, which one is more or better ventilation? So the lower alveoli are better ventilated when the air comes because they have more chance of expansion. Is it? Okay. Great. All right. It's the same thing actually, showing you if the alveolus is already bigger in size, then it will not receive more air. Okay? If the alveolus is smaller in size, it can receive more air and it can become bigger. And if you calculate the total volume coming in the lower alveoli or the upper alveoli, you will say lower alveoli receive more volume because they expanded more. Okay. Upper zones. Can I say that the upper part of the lung or the upper zones of the lung, they have less pleural pressure or the lower value of the pleural pressure, and they are distended, more distended or bigger in size. Okay? And because they are bigger in size already, they cannot stretch much really and they are less compliant. Okay? So negative pressure more, size is bigger, but compliance is less, coming down. Okay? Pleural pressure is okay, more. That's why the size of the alveoli already is not that much big, but if you fill them, they will receive more air, so they are more compliant. Agreed, all of us? No confusion? Please, this is all understanding really. Okay? Lower zone, just opposite effect, we have discussed that. Okay? Now, distribution of ventilation, Shabab. Look at the slide and see, if you have to make a statement, do you think this statement is right that lower parts of the lungs which are dependent parts are those parts which are affected by the gravity, isn't it? These parts are affected more by the gravity. Okay? More blood flow is coming and there are more solid areas and the pressures are also higher in the lower part, size of the alveoli are different in the lower part, and these parts receive more ventilation as compared to the wast of the lung or the upper part of the lung. Yes or no? Yes. Everybody is agreeing with that? Yeah. Yeah. Yeah, please.
Why is that? Why? Is it the same size?
Yeah. Shuf, we talked about that lower parts, okay, contain a little smaller alveoli in size. Okay? So when the ventilation is coming, more lower alveoli will be filled because they have more space to fill. Okay? And yeah.
What about the other one?
Upper one will also receive ventilation, but they're already of this size, bigger size. So if the ventilation is going in them and the ventilation is going in down, the downward alveoli are filled more because they have more space to extend themselves. Okay? And the upper alveoli are taqriban partially filled. So if you add some more air, they will slightly fill more. So overall, where will the ventilation go more? In the lower alveoli. Less ventilation in the upper alveoli. They are already filled because their size is bigger as compared to the lower. I am talking about the new air which is coming. So jareed air will go into which alveoli more? Lower or the upper? Lower. Okay? Yeah.
Naturally bigger?
Yeah, naturally means because at any time our pressures are different. So the size is mukhtalif, naturally. Okay? It's not equal in size. That's why. Alright? Yes, dear. Elasticity is same. But if you have one balloon, okay, which is mawjood, you have filled that one. It is this much filled. And if you have another volume or balloon which is this much filled, Now you are bringing air in two balloons, okay? Which balloon will receive more air, the lower balloon or the upper balloon? Lower. I'm not talking about the end result, I'm talking about the new air which is coming. So the lower will receive more new air, isn't it? Yeah, elasticity is same, I'm not saying that, but their filling is different actually, okay? Okay dear. So now we have developed one concept about the alveoli, that alveoli are not equal, they are affected by different forces and they are filled in different volumes. Yani upper alveoli are filled less and the lower alveoli are filled more. So upper alveoli are less ventilated and lower alveoli are more ventilated when the jadid air is coming into the system. Did you get this idea? Okay. We are agreeing and then we are leaving this statement and we are going to next area, that is perfusion. Okay. Shabab, I don't want anyone to be confused about that. If you don't understand, I will explain it again, but it is important that you keep this concept of the alveoli. Okay. Now dear, look at the perfusion. Perfusion means the blood flow we talked about. Okay. Perfusion, total perfusion of the lung system. How much blood is in 1 minute passing through the lungs? It is the same blood which is passing through the all other parts of the body in 1 minute, which is equal to the cardiac output, isn't it? So your cardiac output is 5 liters or mumkin 5.5 or mumkin 6. Yani it has a range. But average value that we take in most, it's 5 liters, khamsa liter, khalas. So khamsa liter is passing through the lungs. So the blood flow of the lung or perfusion is 5 liters. Now Shabab, can you quickly go back and match this one with the ventilation, alveolar ventilation? How much was the alveolar ventilation? 4200 ml or 4.2 liters. Okay, and perfusion is 5. Which one is more, perfusion or ventilation? They are not equal, they are not showing complete tawazun. Yani ventilation is apparently less and perfusion is more, but that ventilation which is less is kafi, it's enough for the perfusion to oxygenate the blood. So don't think that it has to be equal, it's not lazim. Okay, 4.2 is your alveolar ventilation and your perfusion through the lung capillaries. Now I'm talking about the alveolar capillaries or alveolar perfusion. If I say the pulmonary blood flow is 5 liters per minute, now I change my word and ask you a question. How much is the capillary blood flow happening in all the capillaries of the lungs? I'm saying how much blood perfusion is passing through all the capillaries of the lungs, both lungs, all the capillaries. How much blood flow is passing through all the capillaries in 1 minute? What do you think? It's the same blood flow. Okay, shuf. If I say what is your pulmonary arterial blood flow in 1 minute, what is your answer? 5 liters. If I say no, I'm saying now I'm talking about the blood flow in the medium sized arteries of your lungs, all the medium sized arteries of the lungs. What will you say? 5 liters. Now I say no, I'm talking about all the pulmonary arterioles. How much is the blood flow in 1 minute? 5 liters. Now I say no, I change the level. Pulmonary capillaries, how much is the blood flow? Say how much blood is flowing in pulmonary veins in 1 minute? The same concept, the same blood is going and moving. You are considering different levels only. So my question is again, alveolar blood flow or alveolar perfusion, how much is that? 5 liters. 4.2 is your ventilation and 5 liters is your perfusion. These are not exactly same. Do you agree with that? Okay. All right, boys. This is not a new diagram. This is an old one. You have seen many diagrams like this in your CVS also. Okay? Look at that. Just for a minute, have a look at the diagram and you will find some differences in the values or the pressures which are maktoob here. The pressures are written here. The values are your pressures. Okay? If you are looking at this diagram and the pressures are there, Well, what is that central portion? Heart. It is divided into two sides, right and left, and it divided into two chambers, upper and lower, atria and ventricles. And now you can focus that pressures are mukhtalif in different areas. Right side of the heart, left side of the heart. Are the pressures equal? No way. How can it be? Left heart belongs to your systemic circulation. Right heart belongs to your pulmonary circulation. Which one is lower? You can see the difference. So lower pressure bed. Now you go for the systemic arteries, the difference in the pressure, systemic arteries. Is it same? No. Much different, okay? It's written 25 by 8 or 120 by 80. What do I mean by that? Systolic. You are comparing systolic and diastolic. So look at the systolic pressure in the pulmonary artery. Look at that. 25. Khamsa Shreen bas only. And look at that. It's mere, okay, 5 times difference taqriban, 5 times difference, isn't it? Okay. Look at the pressures in the capillary bed, capillaries of the lungs and capillaries of there, okay? The difference. Well, average pressure here is taqriban close to 17 to 20 like this. 20 is maktub here. You can consider from 17, 18, 19, 20. This is your average pressure in the system. And if you're coming here, your pressure is here like 7, 8 pressure is maujood here taqriban. Alright? So, a big difference really. Here it is very low and here it is a good pressure in the capillaries. Alright. This is the diagram showing you a comparison of the pressures, please. Okay, so pulmonary system is definitely a low pressure system or low pressure bed. Now, this diagram, this animation is showing you nothing special. It's simply showing you that the blood is passing through the baskets of the capillaries which are surrounding the alveoli. Okay, and the blood is coming. The blue vessels are bringing the blood and the red vessels are taking the blood. The blue vessels are definitely the arteries because they are bringing the blue blood. Blue blood, yani, blue means you are saying, it's not blue actually, it is the same red blood but shown with the blue color, isn't it? Just to show you deoxygenation, that's it, okay? Anyway, this is the diagram, and at the same time, can you see that when the blood is passing through the capillaries, now you are looking at the RBCs and you are having the movement of the RBCs. And they are moving, the blue RBCs are changing to red RBCs. What is happening there? Oxygen. Again, you are adding oxygen, attaching oxygen. So, slightly the color of the RBCs is changing as you move from deoxygenated blood to the oxygenated blood. This phenomenon is happening in the capillaries of the lungs. Okay? So, this is a very simple diagram, just reinforcing your concept that what things are happening in pulmonary capillaries. Oh, yeah. That is now again a challenge to understand. The second challenge now is coming up is this diagram. Okay? Shabab, this diagram is showing you some divisions. Do you see that? First of all, what are you looking at? Like lungs in the lying position or in the straight position first of all? Most likely it's the straight position of the lungs, and you are dividing lungs into how many zones or parts? Okay, upper, middle and lower. That's easy, no problem. Okay, now you look at the diagram, apex above and the base below, you know. Okay, pressures are definitely different here and the pressures are different there. Okay, just like pleural pressure was changing in different parts of the lungs from above to below. Was it changing? What do you think about the blood flow if you are having like this, standing like this, and blood flow is maujood in every part of your lungs? This is the lowest part of the lung and this is the upper part of the lung, and the blood flow is affected by the gravity also. One was hawa, that was air. Okay, that was affected. The pleural pressure was affected there. Okay, and now this is about the blood flow. Which one will be affected more by the gravity? The intrapleural pressure, do you think, which was the negative pressure, or this hydrostatic pressure which is maujood in your blood vessels. Which will be affected more? The blood vessels will be affected more. Yani, if I say which part of my lungs will have the highest blood flow? The lowest part. In the natural position, the blood flow is not equal because it is affected by gravity, and much more than the pleural pressure it is affected. Okay, it is affected much more. So my gravity is affecting my blood flow in the lungs very much really. The lowest parts have a very high blood flow, the middle parts have good blood flow, and the upper parts have less blood flow as compared to the other two parts. Is it okay? All right. You are dividing the lungs into three zones. The size of the alveolus in the upper part, middle and the lower part, you know the size, okay? This is the blood supply coming, this is about the capillary, and this is about the veins, okay? The color of the artery and the vein, you know that it's opposite, okay? Blue and red. It's lungs actually, okay? And this is capillary. PA is the alveolar pressure, the pressure of the alveolus, okay? PA, small a, is the pressure here, arterial end, okay? Here in the arterial side. And PV is the pressure here at the venous side, first of all, okay? Now what you are looking at in the diagram is that PA, yani your alveolar pressure, is more than your arterial pressure, and it is more than venous pressure, okay? The upper parts of lungs are very strange areas, okay? They receive less ventilation, yes or no? Okay? The size of the alveolus is bigger, all the time the size is bigger, okay? They also receive less perfusion as compared to the lower part, yes or no? They also receive less perfusion, okay? The blood flow which is going through the upper parts of the lungs, okay, this blood flow is like very strange blood flow, okay? If you are considering the zone 1, okay, in zone 1 there is no blood flow because your alveolar pressure is so high that alveoli, they compress the capillaries and they do not allow the blood flow to pass through the capillaries. But how is it mumkin that if the blood is not flowing there, then what will happen to the upper parts? Zone 1 is a condition, makhsus condition, in which the blood is not flowing through the pulmonary capillaries in the systole of the heart or in the diastole of the heart. In both the phases, your alveolar pressure remains more compressing and compresses the capillaries, okay? Imagine that. But is it really mumkin in a normal person? Do you feel comfortable with this explanation? No, that this part of your lung is not really receiving the blood properly and the blood is not flowing through that. It's not mumkin really, isn't it? But the zone 1 actually is a special condition which develops in some pathologies. It is not majood in the normal condition, okay? But it can happen. If there is some problem in the blood flow of the lung, it decreases. Which part of the lung will be affected first? Upper part, middle part, or the lower part? It's very easy because upper part already has a little blood flow normally, okay? And if there is circulatory shock or if there is hemorrhage, what will happen to the blood flow in the upper part of the lungs? It will decrease further, okay? And there is a chance that zone 1 can develop in that part. So if I say that a person develops shock, circulatory shock, a patient develops circulatory shock, and he is in the sitting position, he is not lying down, he is in the sitting position, which parts of his lung have a chance to have zone 1? Upper part, middle part, or the lower part? Upper part definitely, because upper parts are already poor in their blood supply. And in shock, imagine what will happen. Further decrease in the blood flow. So zone 1 is not majood normal person. Right now we are sitting, all of us are sitting, I am standing. Do you think zone 1 is now working in your lungs? It's not, okay? No, we think, but it's not. Zone 1 is not Mawjood. So zone 1, is it a physiological zone or a pathological zone? Did you get that? In some special conditions, zone 1 can develop in the lungs. And if the zone 1 develops, it will develop in which part of the lungs? That's easy. Is it okay? Okay. Now I am coming to the second part. Here, still, PA, arterial, is greater than A and it is greater than V. Okay? So, here your arterial pressure is a little more. So, it will try to force the blood through the capillaries, isn't it? So, what will happen? This zone, the middle zone, is called the zone 2. Okay? In the zone 2, during the systole of the heart, in the zone 2, what will happen? The blood is passing through the pulmonary capillaries because the pressure is higher in systole. But when the heart is relaxing, the diastolic pressure of your pulmonary artery, what was the pressure? Can you go back and 8, thank you. Good remembering, Abu Rahim, very nice. Okay, it's 8. Okay, and Hamsa Ashreen was your systolic pressure. Okay, so when you are having a systolic pressure, the blood is flowing through the lung capillaries. When you are relaxing the heart, the pulmonary artery has a pressure of 8. In that case, the blood is not flowing. So in this case, what will you say? The blood flow is not occurring, it's occurring intermittently, or it is occurring continuously. What do you think? Intermittently. It's going and stopping, going and stopping, going and stopping. Systole going, diastole stopping. Systole going, diastole stopping. This is called zone 2 of the lungs. Okay? Zone 2 is shown in the middle part here. Okay? Alright? Now, zone 3. I am coming back to zone 2 for further explanation, but I just want you to understand the meaning of zone 3. In zone 3, what will happen to the pressures in your vascular system, high or low? So, if you are having systole of the heart, the blood was flowing very good really because already the pressure was high. But when you are having diastole, will the blood flow also in diastole? Yeah, so this is the area where blood is flowing in all conditions, in systole or diastole, all the time the blood is flowing. So zone 3 is a continuous blood flow. Musalsal blood is moving and nobody can stop the blood. Okay? This is zone 3. You understand the definition of zone 1, zone 2 and zone 3, alright? Now, zone 1, keep it on the side. Why? Because zone 1 is not a physiological, it's pathological zone. Talk about zone 2 and zone 3. Now I am standing here. Which zones do you think are mawjood in my lungs? 2 and 3. Or you are saying just 3. You are considering from upper part of the lung to the lower part and you have to apply the answer. You are talking about 2 zones, huh? 2 and 3. Do you think it's only zone 3 from this part to lower part? Or mumkin in some part you have zone 2 and in the remaining part you have zone 3. What is your suggestion? 2 and 3, yeah. So in this position, alhamdulillah, we don't have any pathological zone. But there is a problem, not problem really, but there is a difference. In the upper part of the lungs near the apex, zone 2 is mawjood. Yeah, blood is flowing and slightly slowing down, stopping and flowing and like this. But alhamdulillah, no problem, okay? It's not harming you. In the remaining part of the lungs, from the middle part to the base of the lung, which zone is mawjood? So now in our healthy positions, as we are standing or sitting, we have 2 zones. In the upper part, you have zone 2. And in the remaining lower part, it's zone 3. Did you get the idea? So zone 1 is not mawjood, please. Zone 2? Yes. Zone 3? Yes. Okay. Now, physiologically, this is in which position? Now, I want to sleep. I'm lying down on the bed. Now, say something about the zones. You change your position. This is your position like this. And now you lie down on the bed like this. The gravity will increase or decrease? Will it become equal in all parts of the lungs? Taqriban. Because now your lungs are not from apex to base here. When you lie down, this is the highest point of your lung and this is the lowest point of your lung, which is not much different really, isn't it? Okay. So what do you think? Will you have zone 2 and 3, or you will have zone 3 only, or what? You are lying down. Zone 2 was maujood, zone 3 was maujood. Zone 3 was there and a little zone 2 was maujood. If you lie down, what will happen now? Now your whole lung is taqriban at the same level and the zone 2 is converted into? Oh yes, okay. So in lying down position, your zone which is maujood is yani musalsal blood flow in all the parts of the lungs. Okay, did you get the idea? Okay. All of you, Shabab? Yes. Yeah, zone 1. Zone 1 is a very special zone, which is imaginative zone, not maujood in the normal persons, but it can develop. Okay? Zone 1 means that blood is not flowing through the pulmonary capillaries in one little part near the apex or in the upper part. Okay? Normally it is not mumkin in us. Okay? But if I develop shock, my blood pressure will fall very low, isn't it? If I develop shock. So my pulmonary pressure will not be, Assalamu alaikum, 25 if you want. Okay, just a moment. Yes sir. I was talking about zone 1. It develops in low blood pressure conditions. If my blood pressure is very low, for example shock, what will happen to my pulmonary artery pressure? Will it be 25/8? It will fall to a low value, mumkin 15 or 10/4 or 5 like this. In that condition, do you think it's mumkin that the blood will flow with this pressure in pulmonary capillaries? No, in that condition. So it develops in pathological states or conditions. It's not maujood normally in us. In any condition it's not maujood. Okay? Alright. Now I am playing Kuratul Qadam and I am center forward and I am very active, running here and there, like in 1 minute I am running 10 times here. What will you consider in my lungs now? Yeah, most likely much of my zone 2 will be converted into zone 3, and it's mumkin that if my pressure is very high during the play, then my zone 2 is also converted into zone 3, even though I am in this position. I am running, I am walking and I am active, but because my blood pressure is high, so my zone 2 will be converted into zone 3. So now you know the physiological conditions, now you know the pathological conditions. Where do you apply? Zone 1, zone 2, zone 3. Is that okay? Okay. Great. Thank you. Alhamdulillah. So you handle this concept. Yes, my dear.
Considering zone 2 and zone 3,
yeah.
How come the blood flow is 5 liters in all areas?
5 liter in all area. Shuf. If the blood is flowing through zone 2, then in that part the blood flow is less in the lungs. But this is compensated by more blood flow which is passing through the lower parts or the lowest part. So if you calculate the awsat average of the upper and lower blood flow, it will be total the same blood flow. So it is not equally distributed. In upper part it is low, but then in the lower part it is very high. So when you are taking the average, average will be your same. There is no problem. Okay? Yes dear, any other question? We are moving. Okay. Ventilation perfusion relationships. Now you understand the meaning of ventilation, you understood the meaning of perfusion. Clear? Okay. We are coming to the ratio. Well, this ratio, now why are we doing all this? First of all, the first point which you should start with, that Dr. Wajed, why are you teaching me this? What is the use? Or you ask yourself question, why am I doing this all? Listening to changes in the ventilation and perfusion and confusing states and all that. Why am I doing that? What is the purpose? Apply this first of all. For what? Okay? Yeah? What is the clinical application? Yeah, what is the clinical application? Okay. In some of the conditions of now you are studying two concepts. One is ventilation and other is perfusion. So definitely your mind will go for some diseases which have ventilatory problems or the ventilatory disorders, as asthma, shadid forms of asthma or obstruction, isn't it? If there is obstruction developing in one part or ventilation is not happening properly, then you'll say, okay, maybe in those conditions ventilation perfusion ratio becomes an important diagnostic tool for tashkhis. it helps really, okay? So I'll use that. Then you will go to the perfusion and you say, oh, maybe some diseases are affecting the blood flow through the lungs, okay?
Pulmonary embolism.
Embolism, obstructive vascular diseases. If embolism is there and a big size of embolism is there, then the blood flow is reduced or very much reduced or stopped in one lung or one part of the lung, isn't it? So that will definitely mismatch your ventilation and perfusion. And if you are mismatching ventilation and perfusion, what will be the result of that? If you are having a problem in ventilation perfusion, they are not having, okay, hypoxia means oxygen will decrease in the blood, one chance. What is the second chance? Polycythemia. Polycythemia can happen as, yeah, tawilul mudda. You'll say that after a long time, maybe if changes persist. What else? When you are having hypoxia, what else can you have with this problem of mismatch? Ischemia, hypoxia, okay. pH changes, okay. Why pH changes? Because of what? No, I want to hear the proper word from you. Come on. pH, beautiful word. Thank you very much. But where is this concept of pH coming from? You are in the
Carbon dioxide.
Oh yeah, thank you. Carbon dioxide, Shabab. There will be a problem of oxygen. You are not giving oxygen, and maybe you are not taking the oxygen or carbon dioxide. So that will lead to the pH changes, acidosis changes. Okay, it can happen. All right. So lovely. Thank you very much. These are the problems. That's why we are doing ventilation perfusion. Okay, we are thinking about some ventilatory diseases and some of the blood flow diseases. Okay. All right. Ratio between your ventilation and perfusion, 4,200 and 5,000 ml. If you develop the ratio, will it be Wahid, 1 or less than 1 or more than 1, please? So your normal ventilation perfusion ratio is slightly less than 1. Mumkin 0.8, tamaniya, okay, less than 1. 0.8 is your normal, or 0.85, okay? Because your ventilation is less and your perfusion is more. So the ratio is going down, right? Okay, great. Ideal ratio, okay? Imagine if you are imagining any ideal condition, I'm not talking about our natural body, I'm saying ideal ratio should be 1, equal ventilation and equal perfusion. This is what we think about. But actually in our system the ratio is less than 1. So ideal ratio is not maujood in our lungs generally, and if you're taking the whole lungs, the ideal ratio is not maujood. Is ideal ratio maujood in any part of the lung? We'll see that later. Okay. Now look at the bases of the lungs, please. Base of the lung. Now you're thinking about the lower part of the lungs. Okay. Bases. Think about ventilation in the bases. Think from, don't look at the slide. Ventilation, more or less? All right. Perfusion, more or less? Now you are both are more, okay? You are comparing ventilation and you are comparing perfusion. Both are more, you are saying, more. Are they equally more, or one is more than other? Which one is more than other? Perfusion. So both are more, but one is more than other, isn't it? Okay. So in the bases of the lungs, now you will say which one is more? Ventilation is more or perfusion is more? Now you develop the ratio, ventilation over perfusion ratio. Okay. So this ratio will be less than 1 always. You will have less than 1 going to a lower value, isn't it? Do you agree with that? Now you move yourself to the upper parts of the lungs, the top of the lung area, the apex of the lung. Okay. What kind of ventilation do you have? Less ventilation or more ventilation? Ventilation in the upper part of the lung. As compared to the lower part, you are comparing with the lower part, it is less, right? Less ventilated alveoli, remember? Okay. What do you think about the perfusion as compared to the lower part? So both are less. Okay. Are they equally less, or one is more less than other? Okay, lesser than other, isn't it? Which one is lesser than the other? Perfusion. So now in this case, perfusion is less. Okay, and so in the lower part, what will I say? Is ventilation better or perfusion better? Perfusion better. Okay. What will happen to the lower parts of the lungs? Are they under-perfused or the over-perfused? What will you say? Lower part. Over-perfused? Sure? Bases. What will you say about the apex of the lung? Under-perfused or over-perfused? Okay? You got the point? Both things are changing, but one thing is changing more than the other. So the upper parts of the lungs, they are called the under-perfused parts, isn't it? And the lower parts of the lungs, or the bases, they are called the over-perfused parts of the lungs. Okay? We are slowly developing the concept and the terms. I hope you are getting these points. Okay. All right. Overall ratio, what did I say? Average ratio in the lung is less than 1, takriban 0.8. Okay? But do you think logically that the ratio in all the areas of the lung will be equal 0.8, 0.8, 0.8, 0.8? I'm talking about the awsat when you're taking its 0.8. Okay, maybe this 0.8 is موجود in the middle part more, isn't it? But if you are going in the upper part of the lung and the lower part of the lung, the ratio will not be 0.8 really. What do you think the ratio will be in the upper part of the lung? More than 0.8 or less than 0.8? More than 1. What do you think when you go? So if you are comparing the 0.8, you're taking 0.8 as your middle part or your average value. The ratio in the apex is greater or lesser? And ratio in your bases of the lungs, in the lowest parts of the lung, is lesser or greater? So if it's 0.8, the ratio can go up to 0.3 takriban, 0.3 only in the bases of the lungs. And if you are going to the apex of the lung, the ratio will be definitely higher. How much higher? It can be about talata, takriban 3. It becomes 3. Okay? So you have a wide range of ratio changing. You know the natural conditions I have talked about. So ratio will not be same, mukhtalif ratio in different parts of the lung. But when you take the average of all the parts of the lungs, this average will come to be about 0.8. Did you get the idea? Yeah. Average here in the upper part, apex of the lung. Okay? Here it will be high. Okay? If you take the ratio in the middle part of the lung, it's takriban close to 0.8 or something like that. If you go to the lower parts of the lungs, the ratio is 0.3. Okay, 0.3 here, 3 here, in the middle takriban 0.7, 0.8 like this. You take the average of all the areas, your average will be coming to 0.8 takriban. But the ratio in the upper part and the lower part is different. Okay, in a normal person when I'm standing like this. Okay, all right. So what is the range of the ratio? Between 0.3 and 3. When I say 0.3, which part am I talking about? Thank you. And 3 is? All right, great. These diagrams you will see it yourself. Look at the different ratios given. One figure is showing you VA over Q ratio. VA is ventilation and Q is perfusion. Ventilation perfusion ratio. Takriban, in the upper part of the lung it is 3, around 3 or so. In the lower part of the lung it's becoming 0.6, or even at the bases exactly it becomes 0.3 or something. And in the wast of the lung maybe it's 0.8, 0.9, 1 like this, it is the ratio. Okay? So this is the situation of the lungs. The ratio is changing. Okay? All right. This is what we have already discussed. In the lower part, what will happen to the ratio? Okay? It is another diagram showing you and giving you the ratio that in the upper part of the lung, look at the right side of the diagram, okay? Ratio Takriban 3 or more than 3 is the ratio at the top of the lung. And coming to the lower parts of the lungs, the ratio is obviously, okay? This diagram is not important. Ventilation perfusion ratio is regulated all the time by the lungs. If in one area the ratio is changing, the lungs have mechanism to bring the ratios back to normal, okay? As you can see the diagram here, okay? In the upper part of the diagram, Shabab please. In the upper part of the diagram, perfusion is adjusted to the changes in ventilation. And if your ventilation is changing in one area of the lung, okay, the perfusion will adjust, it will change and it will come back to its closer value so that it matches the ratio, okay. So ventilation changes, the perfusion will also change. If the perfusion changes, ventilation will also try to change. So they are changing in response to each other. First thing you remember. In the upper part, your perfusion is adjusted when ventilation is changing. For example, the blood flow decreases, the air flow decreases in one part. What will happen? The PO2 in the blood vessels will definitely decrease, okay? When the PO2 decreases, the blood vessels have a very special reaction. Shabab, that is very confusing and that is very strange, isn't it? What is the normal response to hypoxia in your vascular system? In your vascular system regarding the blood flow, what is the response? Vasodilation or constriction in your body in different parts. When one area is not receiving the blood properly, ischemia, so what is the response of the tissue? Dilation or constriction? Think properly. Your blood, one area is not receiving the blood, okay? What will that area try to do? Will it dilate the vessel to take more blood or constrict the vessel further? Dilate, okay? Sure. One area of my body is having ischemia, okay? And less blood is flowing. Now this area will do something to prevent ischemia. What will it do? Constriction or dilation for more blood flow? Dilation. If you dilate, more blood will come in that area because problem is mawjood. So vasodilators are released from the tissues. So response of hypoxia in your systemic areas of the body is vasodilation. But response to hypoxia in your lungs is constriction. Wahid area of the body in which hypoxia produces constriction of the vessels is your lungs, okay? So what will happen? If you are having hypoxia, it means your ventilation is less, isn't it? If your blood vessels constrict, then your perfusion will also become less in that area, all right? My one area, one lobe of the lung is having problem in ventilation, imagine, okay? And the blood flow is normal in that, okay? After a little while, what will happen? My perfusion will also become less to match with the ventilation. So this area of my lung will have now vasoconstriction and it matches with the perfusion. You will say why? Because if I am having vasoconstriction here, then my blood, the remaining part of my blood which is coming will be distributed in other areas which are having better ventilation. So it means you are taking advantage and you are going to those areas from where you can get the ventilation. So if one area is kharban, ventilation is less, the perfusion will also become less. How? By vasoconstriction. So that area is no problem for some time. The other areas will receive more blood and hence you can get more oxygen from the other areas. So it's a distribution of the blood flow which is happening. From one area you are decreasing the blood flow, in other areas you are sending the blood, so you are redistributing the blood, okay? This is a very special thing, unique thing about the lungs, that lungs produce vasoconstriction in that area where hypoxia or less ventilation is mawjood. Clear? Okay. If there is increased ventilation, opposite thing happens. That area will also try to have vasodilation and that increases the blood flow. So that area becomes better ventilated and perfused and it will match, okay? The opposite thing happens now. Your perfusion has problem now, not the ventilation, perfusion, the blood flow. It is now decrease or increase, and now ventilation will change according to the perfusion. Okay, it's opposite thing. If your blood flow is decreasing in any part of the lung and your ventilation is normal, blood flow is decreasing this time, blood flow. Okay, what will happen if the blood flow is decreasing in that area? What will happen to the alveoli? Okay, the alveolar gases will change. Alveolar PCO2, what will happen to alveolar PCO2? Decrease or increase? Decrease. Okay, when the alveolar PCO2 decreases in the alveoli, there is a response of constriction of the bronchioles. Okay, there is a special mechanism by which bronchioles constrict. If the bronchioles constrict, what will happen to the ventilation now? Decrease. So the decreased blood flow is causing decreased. Okay, it's matching or bringing it close to each other. Opposite side, please. If the blood flow is increased, your PCO2 will be increased because more carbon dioxide is coming in your alveoli from the blood, isn't it? Increase. If it is increased, then you will have bronchodilation. Okay, bronchodilation yani more ventilation. When you have more ventilation, it matches with the more blood flow or the new blood flow, isn't it? So alhamdulillah, very nice mechanisms are maujood in the lungs to control ventilation perfusion. So normal lungs try to match ventilation perfusion. One qanoon, if ventilation is decreasing in one area, what will happen to perfusion? It also decreases. If ventilation is increasing in one area, increase perfusion. If perfusion is decreasing in one area, ventilation will also decrease. And if perfusion is increasing in one area, then ventilation will try to match with it. Okay, did you get the idea? Okay, please. This is actually one statement. We are talking about the apex of the lung and the base of the lung. Okay, we have done it, apex and the base of the lung. All right, apex of the lung. Okay, when you are talking about the perfusion, remember the word perfusion, apex of the lung and the base of the lung. Which one was over perfused and which one was under perfused? Apex was under perfused, and if the apex was under perfused, can you say that it is over ventilated? In the other words, isn't it? It is under perfused, but at the same time it is over ventilated as compared to perfusion. Okay, so now you are looking at the relationship. If it is under perfused here, yeah, it means the opposite side is it is over ventilated. So what do you say about the base of the lungs? Under perfused or over perfused? Over. If it is over perfused, can you say that it is under ventilated comparatively? Right? No confusion about the terms? Thank you. Great. These terms are sometimes confusing, but if you have a concept, there is no problem. Okay? Matching and mismatch. This is matching. When your perfusion is less, your ventilation is also less. Matching taqriban, isn't it? Equal. And no problem, that area will receive the oxygenation properly. Red color is, ahmar is showing you oxygenation, and this is showing you deoxygenated blood. So if an area has a matching, the blood flow is less and the perfusion and ventilation are matching, then your oxygenation will be equal and you will have this one. Okay? This area less blood is passing, but whatever blood is passing, is it getting oxygenated, yes or no? Okay, great. Yeah. Low blood flow, low ventilation. Okay, this oxygen is showing you ventilation. This is showing you perfusion. Oxygen is ventilation. This is perfusion. They are matching with each other. When they are matching with each other, what is the result? Normal oxygenated blood, no problem. Here the blood flow is good and ventilation is also good. So what is the result? Very good, no problem. Here the perfusion is high and ventilation is also now matching and it is also high. So the result is Normal, okay? Look at this side. This side will have a little problem, okay? Look at the color of the oxygenation. Is it really amber or different color? So it means less oxygenation is happening, isn't it? Okay. Look at this one. Here, more perfusion and less ventilation. Do you agree with that? In this part of the diagram, seems equal really. If you compare with the other part of the diagram, it looks equal. But what is actually happening? What do you think is happening? It's not equal. Actually, the diagram is not shown properly. But yeah, it is not equal. If it is equal, then it is not a mismatch. Okay, it is a mismatch condition, and the result of mismatch is low oxygenation. In this, the blood flow is taqriban equal, isn't it? The blood flow is coming, and maybe the size of the oxygen ventilation should be a little smaller than that, smaller than this one. So some mismatch is mawjood. If some mismatch is mawjood, imagine what will happen? The oxygenation will be less. It is not equal. Both things are not equal actually. Imagine this is a little smaller, okay? A little smaller, slightly different, not exactly matching with each other. If they're not matching with each other, what will happen? Okay, mismatch. Look at this one. It's a big mismatch really. Okay, look at ventilation. More ventilation. Look at the perfusion. Less. Definitely this will have a new thing. Okay. From this here, do you see the difference in the color? This color, and this color. So oxygenation is increasing or becoming better and better. In this, where do you have a maximum mismatch? Okay, yeah. The upper part, it is mismatch. This part is also mismatch, but the results of the mismatch are different, isn't it? This is also a mismatch, big mismatch, but this big mismatch is causing oxygenation, no problem. Okay, because ventilation is kathir, no problem in this area. This type of mismatch is a bad mismatch. Why bad? Because yeah, the blood is not functionally oxygenated properly, isn't it? So just to show you that mismatch results are like this and the matching results are always like this. They are equal, isn't it? Okay. Oh yeah, please be careful. Last parts of our discussion, okay? I know your energy levels must be dropping because it's a Tawil lecture, but here it is a very, very important area coming up. Okay, what time is it now? May I know the time? Okay. Okay. I'll stretch for like 5-6 minutes more and then I'll give you the break. Okay? And then after the break we'll gather again inshallah. Because I want you fresh really to understand. Okay? Now, you are using two Jadid terms, very important. This is your application. When you do medicine, you will use these terms, please. Okay? This is important. What is the meaning of shunt? Shunt means you have a problem in the ventilation perfusion ratio. What type of problem? Shuf. Shunt, this is your ventilation. Like this. Up and down is your ventilation. And this is your perfusion. This is perfusion. Okay. Now see my hands. Alright? See my hands. Okay? This is ventilation and perfusion, and this is perfusion, this is ventilation, inspiration and expiration, like this. Okay? We are talking about shunt. Look at my hand. It's only perfusion. Okay? Yani what is missing? How much? No. Okay? Some blockage, complete blockage in the system. Yani ventilation is not happening in this area. Only blood is flowing. But is it any use to have the blood flow? Will that blood be oxygenated? This blood is called the wasted blood. Wasted blood. It is wasted actually. It is passing through this area and this area is not giving oxygen. So this blood is wasted. Okay? This is called wasted blood flow or wasted perfusion. So that blood is said to be shunted. The blood which is not getting oxygen is always called shunted blood. Shunted blood yani not receiving oxygen. Okay? Why? Because your ventilation is stopped. Okay, this is called absolute shunt. Okay, absolute shunt means zero ventilation in one area and perfusion is normal. Okay, normal perfusion and zero ventilation. All right, normal perfusion, zero ventilation. What will happen to the ratio in this area? You will put cipher in place of ventilation and you will put a normal value in place of perfusion. What will be the result? Zero. Okay, so when the ventilation perfusion ratio becomes zero, cipher, it means you have a problem called shunt, and shunt means that the blood is flowing but ventilation is not موجود in that area. Okay, shunt means no ventilation and perfusion is موجود. The ratio will become zero. If it is absolute condition, yani if the ventilation is صفر, the ratio will become صفر. Okay, clear all of you? This is shunt. So the ratio becomes zero. Now dead space, you have an idea about the dead space already. Okay, dead space is that area where no blood, yeah, no gas exchange, yani you are not sending that oxygen or exchange in that area. Okay, you call it dead space. Now look at this other part of the picture. Now look at my hand. Okay, what is happening? Only ventilation. Is there any perfusion? No perfusion. This time what is missing? Perfusion. Okay, zero perfusion with normal ventilation. Okay, what will be the ratio? VA over Q ratio. You cannot calculate that ratio because cipher is موجود below and above you have a value. It's infinity, really, unlimited, uncountable. So the ratio becomes infinity. So when you have normal ventilation and no perfusion, this condition is called dead space. Now look at your ventilation. Your ventilation is coming and it's going. Any use, shughal of this ventilation? No, it is wasted ventilation. You are wasting it. It's no use really. Okay, so I am saying it again. Wasted perfusion in which condition? Shunt or dead space? Shuf, again. Wasted perfusion, wasted perfusion, wasted perfusion in which condition? Shunt. Wasted ventilation, no use of ventilation. Oh great. Okay, so you got the concept of the shunt and you got the concept of the dead space. In the dead space, the ratio is absolute dead space when there is no blood flow, no perfusion. What will be the ratio? Okay, but if there is more ventilation, and ventilation is normal and your blood flow is less, it is موجود but it is less, what will happen to the ratio? Increase more than 1, definitely. Okay, so it means dead space means that your ratio is increasing, and if it is absolute dead space, your ratio will go to infinity. So increasing ratio means dead space is موجود in some area. All right, and if it is complete absence of perfusion in that area, then your ratio will become infinity. Okay, so ratio more than 1 is showing you what phenomenon? You are talking about dead space. Okay, in that area definitely ventilation is much more and perfusion mumkin it's bad. All right, so when I say dead space is موجود in this area, you say okay, ventilation is definitely more than perfusion, so this area will develop dead space. Okay, absolute dead space is not موجود. Okay, relative dead space is موجود, yani ventilation in one area is more than the perfusion, so that area will have dead space. Okay, you got that? Now if your area is having no ventilation and good perfusion, okay, no ventilation, it becomes cipher, isn't it? And if your area has little ventilation and normal perfusion, okay, that area, the ratio will become less than 0.8 or the normal ratio, it will go down. towards which area? Cipher. You are moving towards cipher, isn't it? Okay. Cipher will develop only when there is no ventilation. Okay. All right. Now you tell me dead space and shunt. You got the meanings. Okay. Anatomical dead space and anatomical shunt. I'll begin with this very quickly. Once I finish, I'll stop here and give you the break. Anatomical shunt means in our system, some shunt is modular due to anatomy of our vascular system. Okay? When I'm saying shunt, it means your blood flow is passing, but this blood flow is not getting oxygen. This is the meaning of anatomical shunt. Do we have any blood flow in the body which is passing through an area, but it is bypassing or not getting oxygen? Do you have any kind of blood flow in our area of the body or in part of the respiratory system or in any part? Is there any type of blood flow which is not getting oxygen from the lungs? It is bypassing. Anatomically, there are some blood vessels maujood which are taking. Anatomically, I am saying that. Okay, it's not the functional, anatomical. Yeah. This is maujood in your respiratory system. Okay, it is a part of systemic circulation, but maujood in your respiratory system area. Bronchial vessels, please. Shabab, bronchial arteries. Where do they come from? Aorta. Okay, these are the branches of the aortic vessels. Okay. Bronchial arteries will supply the lung structures, the bronchi, bronchioles, septa and elastic structures and the tissue stroma of the lungs. Okay. After bronchial artery has supplied, bronchial artery was bringing oxygenated blood or deoxygenated blood to the lungs? Oxygenated, normal blood. Okay. Supplying the lung structures. So the lung structures are supplied. After that, the blood passes in bronchial veins. Bronchial veins will contain deoxygenated blood or oxygenated blood now? Deoxygenated blood. Now, where are bronchial veins going, Shabab? This is the question. They are going directly to left atrium and opening into the left ventricle. So, if they are going into the left side of the heart, are they receiving oxygen from area? No, shunting. So, if I say anatomical shunt, which blood will come in your mind? The bronchial venous blood. That is your anatomical shunt, which is maujood normally. Okay, little amount, very little amount, but maujood. Okay, this is called anatomical shunt. Okay, all right. Now I'll talk about one more type of shunt. It is called the alveolar shunt. Okay, alveolar shunt. When I say alveolar shunt, what do I mean by that? Alveolar shunt. I say alveolar shunt is maujood in this area of the lung. Alveolar shunt is maujood in this area. So what do I mean to say? What is happening in that area? Blood is passing through that area, but ventilation is little or less or mumkin not maujood in that area, isn't it? So that area will develop alveolar shunt. So how many types of shunt have I told you? Anatomical and alveolar shunt. If you combine these two shunts together, total shunt, this is called the physiological shunt. Okay, anatomical shunt, alveolar shunt is known as the physiological shunt. Okay, this kind of physiological shunt, okay, is maujood in normal person also. Do you think normal person also has this shunting? Yes. It's mumkin. Which part of your lung, now applying your concept again, which part of your lungs will have physiological shunt? The upper part, the middle part, or the lower part? Shunt means what? Yeah, give me one answer, okay? You are having more blood flow in that area and you are having less ventilation in that area comparatively. Which area is that? Your basis of the lung, the vast of the lung, or the upper part of the lung? So if I say that all of us have some physiological shunt maujood in our lungs, which area will you consider? Base of the lung. So the lower parts of the lung, thank you very much, okay? It's the bases of the lung, yeah? It's lowest part of the lungs, not the whole zone 3, I am talking about the lower part, but generally in the zone 3 you have a chance of yes. Okay, all right Shabab. If I say no, we also have a little part of physiological dead space मौजूद. Awwal, dead space. I am coming to dead space, please. Anatomical dead space, where is it मौजूद in us? Anatomical. Remember that? From nose to? Thank you. I say some alveolar dead space is also मौजूद in some parts of my lung. Normally, alveolar dead space. Which part would that be? Middle part, upper part, or the lower part? Apex of the lung. In the apex of the lung, your blood flow is less really, okay, and your ventilation is better than your blood flow, isn't it? So what will happen? If you combine alveolar dead space, which is मौजूद in upper part of the lung normally, okay, it's मौजूद, little is मौजूद, with your anatomical dead space, which is also मौजूद, you will call it physiological dead space. Now I say physiological dead space is मौजूद generally in which part of your lung area? Upper part. If I say physiological shunt is मौजूद in which part? Normally. So some shunt physiologically is मौजूद, normal. Some dead space is मौजूद physiologically, mumkin in the, and in the middle part of the lung it's very good, okay, it's equal. So upper and lower parts of the lungs are showing you physiological dead space and physiological shunting respectively. Am I clear about that? Okay, this is physiological, but in pathological conditions many areas of the lungs can develop dead space or the shunt. So now you understand the basic khayal, the basic concept of shunt and the dead space. Am I clear, Shabab?
Repeat the alveolar shunt.
Alveolar shunt. Alveolar shunt means, when I'm saying alveolar shunt, in that area the blood is passing in the capillaries, but your ventilation of the alveoli will be little. So your blood is wasted. This is happening in your base of the lung, lower part of the lung, where more blood is मौजूद and less ventilation is मौजूद, isn't it? Okay, so shunt is मौजूद here, alveolar shunt, and we also call this area as physiological shunt, lower part. Am I clear here, Shabab? Okay, I think I'll stop here to give you a break, okay, and few slides are left, but I'll continue it when you come after some time and fresh yourselves, have chai or coffee or something to eat, okay, and take your reserve, because we are here till 12 o'clock or so. We have another lecture of mechanism of breathing. Freshen yourself and then come back inshallah. Thank you very much. I'll see you later. I believe taqriban all of us are back now, okay. First of all, I'd like you to sign the attendance sheet. Is it here with you? Anyone? No, not here. It's there. I'm sorry, okay. Bara, please start. Attendance sheet, okay, sign your attendance so that we don't waste time. Okay. Shabab, so far what we have discussed, did you get the idea? From the basic, we started from the alveolar ventilation. We talked about different areas of the lungs. They are mukhtalif in their alveolar size and the pleural pressures, and the blood flow is also different in different parts of the lungs. Then we talked about the ratio. How do we develop ventilation and perfusion ratio? And we saw that ratio is not same in all the parts of the lungs. There is a range of the ratio. You know, from upper part of the lung, the ratio is high, taqriban talata, or more than talata or nus, like this. And in the lower part, it's 0.3, 0.5, something like that, the ratio. In the middle, the ratio is in the middle, taqriban wahid or tamaniya, like this, 0.8, figure is like this, okay? We talked about two very special concepts, clinical concepts. One is shunting of the blood and other is dead space development. But before that, we saw that first, let's see, do we have under normal conditions some shunt मौजूद or some dead space? We say yeah. And then we applied our knowledge and we saw that in the upper parts of the lungs, there is more chance of developing dead space, right? Am I right? And as you go in the lower zones, regions of the lungs, naturally speaking, there are more chances of the shunting of the blood, okay? I'm not talking about absolute shunt or the absolute dead space, but relative shunt. Yani mumkin some shunt, yani there is a difference in the blood flow and the ventilation. In the lower part, yaqinan, the blood flow is more, definitely it's more, and your ventilation is comparatively less, okay? Underventilated, over perfused, like this. In the upper part, your Perfusion is a little less, but your ventilation is a little more. So over ventilation and under perfusion like this. So in this way, when you develop the ratio, you will see the ratio is high in the upper part and the ratio will be low in the lower part. The high ratio is known as dead space, right? High ratio is dead space. And when you are going to the low ratio, you are going towards the shunt side. This is your basic concept so far, okay? I believe no one is confused about the basic concept so far? Great. Normal. Look at the picture only. It's only tasveer, but showing you normal, right? This is showing you the ideal ratio, and I said ideal ratio is the ratio which is Wajed, 1-to-1 matching really, okay? Normally our awsat, when you calculate the average, it's not 1 over the lung, it is a little less than 0.8 taqriban, okay? But it's close to, it's qareeb to 1, yani, okay? But do you think if your ventilation perfusion ratio normally is going from 3 to, and it's decreasing and it's decreasing and it becomes taqriban 0.3 here, somewhere in the movement the ratio is Wajed also? When you are going from 3, then you are having 2.9, 2.8, 2.7, 2.5, 2, 1.5, 1.4, 1.3. So there comes one area of the lung, mumkin some part of the lung in the middle, that the ratio will be Wajed also, ideal ratio. So can we say that it is imkan, not imkan actually, it's true, that in some part of the lung, the ideal ratio is mawjood, isn't it? But the average ratio, when you take of all averages, that is slightly less than 1 or 0.8. Am I clear about that? Okay. So don't confuse with the ideal ratio. Practically we are talking about our natural ratio or the average ratio. Our average is 0.8. But that 0.8 is very, very close to the 1 value. Okay? Now look what is happening here. Ventilation is coming and going, and perfusion is not happening, so you are wasting ventilation. No use of that ventilation really, okay? So the problem is with the blood flow. There is no problem, mashallah, with the ventilation. It was perfect, isn't it? So high ventilation and your ratio is going up, and if there is no perfusion, ratio is infinity, okay? So when the ratio is increasing and going towards infinity, mumkin it is increasing from 0.8, it's becoming 0.9, 1, 1.1, 1.2, 1.3. You are going in the region of dead space, okay? And when your ratio is dropping from 0.8 towards sifar, it's going sifar. So what you are doing, you are developing shunt. As your ratio drops more and more, your shunt is becoming more and more. As your ratio is going up more and more, your dead space is becoming more and more. Am I clear about that? Okay. What is here happening? You know it. We are just repeating it so that it becomes clear in our mind. From pictures, from discussion, from the writings, and this is what we are doing to understand. Okay? Same thing. You interpret your diagram yourself. I am leaving this diagram. This side you are going, your ratio is going towards sifar in this side of alveolus. Okay, when you are going towards this side, I'm sorry, when I am talking about, because I am looking here, so that's why. When you are going in this direction, okay, what is happening? Your ratio is going towards sifar. Yani you are going down in the ratio. Yani you are going towards shunt. When you are moving in this direction, okay, and then you just interpret the changes, what will happen in your alveoli, gases, what will happen to the pressures in the gases. Not really important, but this is something which is happening in your alveoli. Okay, the gases will definitely change. Okay, it's a self-study slide. I am leaving it to you actually. Okay, it's very easy. Shunt. Okay, I am just giving you a khulasa of shunt. You know, right? Okay. Absolute shunt is your anatomical shunt, okay, which is V over Q is 0 in that. we consider. Relative shunt means when you are moving towards ratio less than 0.8, then you are developing relative shunt. But when your ratio becoming صفر, then you will call it absolute shunt. Likewise, now we'll talk about later. So, relative shunt, you know the meaning. Shunt estimated as venous admixture. Venous admixture was the phenomenon which is happening when your bronchial blood is coming into your qalb directly. Do you remember that? That is called venous admixture. Why do you call that as venous admixture? Because you are mixing a good blood mawjood in your left atrium, oxygenated blood, with a little amount of deoxygenated blood. In your left atrium, you are receiving two types of venous blood. Awwal, oxygenated venous blood, which is coming from pulmonary veins, and a little amount of bronchial venous blood, which is the deoxygenated blood. So when you mix it, this mixing is called venous admixture. So if I ask you, in our body, what is the place where venous admixture is happening naturally, what will be your answer? It's left atrium. You will say left atrium is the awwal place where two bloods are coming and mixing with each other. Am I clear? Normal shunt, which is mawjood, some shunt is mawjood in us, okay? Yani total shunt. Anatomical, alveolar shunt. This is known as physiological shunt. Overall, the shunted blood in our body, which does not receive, shunted blood means not oxygenated, right? Okay? Poorly oxygenated or not oxygenated blood is called the shunted blood. Out of the total blood of our circulation, in percentage, how much should be the normal? Naturally, it should be less than 5%. It's 2, 3, 2, 3, 2, 3. Mumkin, it is a little more in some persons. Okay. But if it is more than 5%, is it a normal condition? Something more abnormalities developing, and there is some disease in the lungs in which they are, problem. Some problem, perfusion is going on and your ventilation is probably not good in some places. Is it okay? All right. So we know the meaning of the slide here, right? Very quickly. Oh yeah. Just 1 or 2 points about this slide, really, that when you have the shunt, what will happen? There are some under-ventilated alveoli and there are some over-ventilated alveoli. Okay, I am using two terms: under-ventilated, which receive, and over-ventilated. Okay, if there is an under-ventilated alveoli, what will develop in that area? Shunt or dead space? Shunt. If there is an over-ventilated alveolus, what will develop in that area? Dead space is developed. Okay, it's simple thing. All right. If there is over-ventilation happening, more ventilation is coming, it will take the carbon dioxide very easily. It will remove carbon dioxide from the alveolus. So what will happen to the carbon dioxide level in the alveolus? Because quickly you are cleaning. Carbon dioxide is coming from the blood, but you are more removing carbon dioxide. Yani your pressure of the carbon dioxide will become less in the alveoli. Do you agree with that? Okay. But when you are doing over-ventilation and your blood flow was normal blood flow was there, okay, what will happen? Do you think more oxygen will go into the blood? More oxygen will go into the blood. You are removing the carbon dioxide. You are over-ventilating. Over-ventilating means you are bringing more and more jadid air. More and more oxygen is also coming. Okay. But do you think oxygen is shifted more into the blood also? The blood was already coming normally, not an extra blood coming, normal blood was coming. No, alhamdulillah, that blood was actually receiving normal oxygen from the normal ventilation. Now you are having more ventilation. Your blood is, alhamdulillah, already saturated. Your hemoglobin is already loaded with the oxygen. So it will not really carry anymore. If you further increase more and more oxygen in the alveolus, mumkin, slight increase in the blood oxygen. What type of oxygen will increase in the blood if you increase more and more ventilation and sending more oxygen? Yeah, who said dissolve? Mumtaz. Thank you, dear. Very good answer. Dissolved oxygen is the only oxygen which can increase, because increasing more oxygen will dissolve a little more in the moya, in the water of the blood bus. Okay, oxygen is already attached to the hemoglobin. It is mawjood, alhamdulillah, full. So you cannot add more oxygen into the blood by hemoglobin, but the only way is dissolved oxygen little. Okay, so yani, what is the idea? When I am over ventilating, okay, I am removing more carbon dioxide or I am giving more oxygen to the blood? What do you think? More carbon dioxide. Oxygen is not really changing in my blood by over ventilation, isn't it? Because alhamdulillah, oxygen was already going and my hemoglobin is loaded. I have no problem. This is the oxygen hemoglobin curve, having the special properties of hemoglobin attachment. Awwal is helping second, second is helping third, third is helping fourth, like this, and it is already alhamdulillah mawjood. There is no problem. Okay, this was one point. So that was the idea. So if there are some underventilated areas of the lung mawjood, okay, what will happen to the carbon dioxide in those areas underventilated? It will increase. Okay, but at the same time there are some overventilated areas in the lungs also, and that will give you a tawazun between the underventilated and the overventilated. So overall your carbon dioxide is removed from the body. There is no problem in the carbon dioxide. I told you about carbon dioxide, one property. Is it better than oxygen in movement or slower than oxygen? Better. Why better? Highly lipid soluble. Okay, lipid solubility is mia, okay? Mia fil mia, really. Okay, it's beautiful in its lipid solubility. Anyway, you got the idea, right? Okay, quickly, we are just ending this slide. We are giving final areas. Dead space. You agree? Wasted ventilation. Okay. Dead space is estimated as a ratio VD over VT. If you talk about your dead space, if I say dead space, the first dead space which comes in your mind is from here to here. It's the normal dead space, anatomical dead space mawjood, big one. Okay. How much air do you take in one breath? How much air, total air you take from outside? Okay, 500. Okay. Tidal volume yani 500, right? From this tidal volume, how much, if you develop the ratio, how much air is mawjood in your dead space normally? 150, okay? 150 fil 500. 1/3 تقريبا, okay? It's 450 exactly like this, but it's 500 تقريبا, okay? So 150 over 450, 150 upon 500, so it will be تقريبا 1/3, okay? So 33% or 35%, if the ratio, if you calculate, so your dead space is 33% of your, or 35% of your tidal volume. Do you agree with this statement also? تقريبا, all right? Okay. This is, we have already done so many times. It's just a slide showing you what is the meaning of your anatomical dead space, what is the meaning of your alveolar dead space, and what is the meaning of your physiological dead space. All right, we are all clear about that. Oh yeah, coming to the end of the slide here, we are just putting end to our discussion here, and this is the clinical significance of VAOQ. The whole idea of discussion was to understand these conditions really. Because when you develop a disease, mard, in your respiratory system, definitely it will affect either ventilation or it will affect perfusion, and there will be problems. The ratio will change definitely, isn't it? Look at the diseases. In some diseases you will have ratio, lower ratio. You are going towards the low ratio. When I say low ratio, quickly your mind sparks. It means shunt chance, shunt. If I say, oh, ratio is increasing in this disease, you say, oh, physiological dead space is forming in this condition, in this disease. The body is developing physiological dead space more and more. It's increasing now. Some is already mawjood, but now in this disease, the total physiological dead space is increasing. Okay, so you can go towards two sides in diseases, shunt side, and very interesting, in some diseases in different areas of the lungs, some areas are developing shunts and other areas are developing dead space. Yani it's a combination. I'll give you an example. In emphysema, okay, you are damaging the, in some areas, septa, and the capillaries are also damaged along with the septa, okay, because septal walls contain the capillaries. So what you are damaging, surface area is decreased. Thani, it is capillaries which are reduced. Shabab, if capillaries are reduced in one area, the blood flow in that area is decreased and ventilation is more, it's coming in that area. So you are going towards dead space concept, isn't it? Agree, all of you? Okay. In other areas of the COPD, you know COPD means two diseases. Number one, emphysema, and number two, bronchitis. Okay. In one person, I told you in the beginning also, if you see the complete tasweer of this COPD, okay, some persons have more emphysema in the lungs and a little amount of chronic bronchitis. Some persons have more chronic bronchitis and less amount of emphysema. This is also one type of disease. And some have nus taqriban, like equal amount of emphysema and equal amount of chronic bronchitis, because both are developing together. One is more, other is less. One is less, other is more. 1 and 2 are equal also. It's mumkin. Okay? In emphysema, what are you developing? Dead space. Okay? Now you come to chronic bronchitis. It's the problem of the bronchioles, small, and the bronchi. They are getting degenerated and they are loaded with maybe mucus and they show some obstruction. So what is decreasing, ventilation or perfusion? Ventilation. If the ventilation is decreasing and perfusion is normal, taqriban, you are going towards shunt. So in chronic bronchitis, there are more chances of developing, and in emphysema, there are more chances of developing, and both are happening in the same person. In some areas of the lung like this, in some areas of the lung like this. Did you get the idea? So in one disease, you see a reflection of both processes. Okay? You got that? And in some areas, in some diseases actually, you will have dominantly shunt developing, or you will dominantly have dead space developing. Okay? Like if I say bronchial asthma, shadid form of bronchial asthma, it should be shunting, isn't it? Ventilation is poor, you are not expiring properly, and in advanced form of disease there is a problem in ventilation, blood flow is going on, no problem with the blood flow. So like this. But if there is a case of like an area where you have I would say pulmonary embolism, okay, what will happen? Pulmonary embolism is developing and blocking one thrombosis. Okay, a tumor is growing in the lung. Listen to me, a tumor is growing into the lungs, and that tumor is compressing one of your big bronchus. It is compressing, and after some time it completely obstructs from outside, it completely obstructs, and after some time your lung, that area of the lung collapses, because now you don't have the exchange, isn't it? It will collapse. So that area of collapse, what do you think is happening in that area of the collapse more? Yeah, definitely. Blood flow is taqriban normal in that area. You are not doing anything wrong with the blood flow. You have no ventilation. Ventilation is khalas in that area, or decrease in that area. So you are going to a shunt. So you can apply very easily what is happening to ventilation in this disease, what is happening to perfusion, and then you will say, oh, shunt or dead space, like this. Clear? Thank you. These are the examples. Okay. You are developing edema. Okay, when you are developing edema, you are going more towards problem in oxygenation. Yani blood is not getting, because edema is mawjood, so your what is the meaning of ventilation? Ventilation means giving oxygen to the blood. Sir, what is the idea of ventilation? Why are you doing ventilation? You are giving oxygen to the blood. If you cannot give oxygen to the blood properly, will it come as a problem of ventilation, or will it come as a problem of perfusion? What will you say? Ventilation. Okay? Even though your ventilation was okay, the problem, but your ventilation is not shifting oxygen into the blood. So it will be taken as ventilation problem, and shunt will happen in this area, isn't it? It's shunted blood. So this edema will also come in the group of shunt, alright? And here you will have definitely some kind of problem when the ratio here. I told you about emphysema, right? I told you about the embolism, we discussed that. I hope I am clear about the diseases, all of us, right Shabab? Thank you. Do I need to explain anything? Any question? No? This is your last slide. Summary is not mine, summary is yours. When you revise this presentation, you will quickly sit and see what is happening in these processes and apply upper part, middle part, lower part, what is happening, and answer the question yourself, okay? It's very easy, right? And thank you very much. This is for your ventilation perfusion ratio. We are done with that one, okay? Abdullah, I need the second one. Is it here?